Cicatricial conjunctivitis can be regarded as the inflammatory conditions that arises in our eyes. Now, what can be the predisposing factors towards these inflammatory conditions? We can regard these predisposing factors as the hypersensitivity reactions. Mainly it is the type 3 and the type 4 hypersensitivity reactions that result in the cicatricial kind of conjunctivitis that we're dealing with. These type 3 and type 4 hypersensitivity reactions result due to the infectious states that occur in the body, as well as it can be the drug reactions towards certain drugs, as well as we have the autoimmune kind of diseases that also result in these cicatricial kind of conjunctivitis states in an individual. Moreover, we have toxic conjunctivitis, which is included along with this topic of cicatricial conjunctivitis. Why is that so? Because it's again a kind of type 3 and type 4 hypersensitivity reactions that occur to certain kind of infectious states, as well as the toxic levels of the different kinds of drugs that the patient is using for any other purposes or any other diseases that are prevailing alongside in that same individual. Now we have these cicatricial and toxic conjunctivitis, and it can be included in the differential diagnosis whenever we have a case of inflamed conjunctiva. We have redness and soreness of conjunctiva, including a papillary reaction that is occurring at the bulbar conjunctiva. The patient is complaining of a foreign body sensation and severe irritation in his or her eyes, which is also resulting in a decrease in the visual acuity. We're going to diagnose this case to be suffering from conjunctivitis. But as long as we're going to just look at this case, we are going to perform a differential diagnosis for this particular patient, including the bacterial, the viral, the allergic, we have the cicatricial, and then finally we have the toxic conjunctivitis. We'd be asking the patient for certain history questions that are really significant over here. It can be the age of the individual. The sex is again one of the predisposing factors over here. The locality, the location, the environmental conditions are again going to be very important for this individual. And then moving on, we're going to just focus on the presenting complaints of the patient. The presenting complaints of the patient would again reveal a lot of factors. For example, it can be the kind of the discharge that is coming out of the eyes along with the conjunctivitis. Either it is the mucopurulent kind of a discharge, it is just a thin watery discharge, or it's just a membranous feeling on his or her eyes, which would be related to this ocular mucous membrane pemphigoid that we're going to study right now. It's again one of the varieties of cicatricial kind of conjunctivitis. As I've already focused on the fact that this cicatricial kind of conjunctivitis are the inflammatory conditions. It can be the autoimmune diseases as well as the infectious or the hypersensitivity reactions towards certain kinds of antigens in our environment. Particularly when we are considering this ocular mucous membrane pemphigoid, we're going to consider what would be the complaints of the patient, the presenting complaints and the history of presenting complaints in this particular kind of patient. Now, whenever we have this ocular mucous membrane pemphigoid, it is basically an autoimmune disorder that is occurring in the individual. The antibodies get attached to the basement membrane of the conjunctiva, and then there is an inflammatory reaction that occurs at the conjunctival level. So this would be the definition of this particular condition that we're talking about. It's an autoimmune disorder. The basement membrane of the conjunctiva is involved here. So if you just recall the anatomy of the conjunctiva, or the histology or the histological features that we'd already studied, we had an epithelial membrane that was just attached to the basement membrane. Then we had a lymphatic tissue underneath it, and then we had the fibrous layer of the conjunctiva, and after that, and finally, we had the conjunctival vascular layer underneath the fibrous layer. So this was the anatomical features of the conjunctiva. Over here, the antibodies are just against the basement membrane of the conjunctiva, but still the inflammatory reaction would flare up. The patient would complain of redness, irritation, increased lacrimal gland flow, increased tearing phenomena would occur in the eyes, foreign body sensation, itching, all of these would be the features of the ocular mucous membrane pemphigoid over here. What is the etiology behind it? The predisposing factors for this condition, which is a pemphigus kind of a condition, would include the type II hypersensitivity reaction that is occurring over here. It is usually occurring in 60 years of age group. So it's almost the 6th decade of life, which is involved in this kind of condition can arise at this level. It is much more common in females rather than in the males. So the history would be again very important over here, the age of the individual, the gender of the individual, and that would really point out towards the fact the kind of condition that this individual can be suffering from. Then the pathology or the pathogenesis, as we've already gone through, it's the antibodies that are attaching to the basement membrane of the conjunctiva. The inflammatory reaction flares up. And there is this layer or the mucous membrane that is formed on the conjunctiva. Conjunctiva, as we all know, it's that transparent layer that is covering the sclera, it's covering the cornea. So if there is any inflammatory reaction that is occurring at the conjunctiva, it's going to involve the sclera. It can involve the cornea as well. We can have the conditions of scleritis, episcleritis as the complications, as well as if we have the corneal involvement, the corneal ulceration, the keratitis, if it is attached to this kind of a condition, or if it is left untreated and the situation is complicated for the patient, it would result in the punctate keratitis, it would result in the basilar keratitis, or even it can result, if it is a long-standing keratitis, it is going to result in the corneal ulcers in the patient, the dendritic ulcers that we've already gone through. So it's basically the fluorescent techniques would be used here just to enhance these dendritic ulcers at the cornea. And as a result of the corneal involvement, what would happen is the visual acuity of the individual would also be decreased at this level. So these can be the further complications if this mucous pemphigoid is left untreated over here. Now, regarding the ocular features, the particular features that we're going to look at when we are looking at a patient of a mucous membrane pemphigoid, we'd be looking at the inflammatory signs. The inflammatory process has started on at the basement membrane, and that's why we look for the hyperemic changes that are occurring at the conjunctiva. They're specifically quite predominant at the canthus, whether it is the medial canthus or whether it is lateral canthus. We have the chronic papillary formations over here. That would be quite evident when we evert the eyelid. We had that papillas that are quite easily seen on the bulbar part of the conjunctiva over here, and that is why it can be confused with the bacterial conjunctivitis as well. We we can also confuse it with the viral conjunctivitis, some forms that specifically the adenoviral conjunctivitis, in which we have that cobblestone appearance, large papillas are formed over there, the giant papillary conjunctivitis. These can be included in the differential diagnosis of this ocular mucous membrane pemphigoid. Only the further investigations in a particular case would reveal that this patient is suffering from ocular mucous membrane pemphigoid or any other condition. Then we have the cicatrizational signs. Cicatrization is basically a word used for scarring. So whenever there is an inflammatory condition, scarring would result in long-standing or in the chronic cases of the inflammatory condition. So we have some sorts of cicatrizational signs as well. We will have the loss of plica semilunaris, that is located most medially at the medial canthus. We have a layer, we have a semi-lunar formation at the medial canthus, which is quite a normal phenomena. Physiologically, it is present over there. It is known as plica semilunaris. And if there is obliteration of plica semilunaris, it is indicating towards some sort of chronic infection or some sort of long-standing infection in the eyes, which can be this pemphigoid mucous membrane in the eyes. Then obviously at the fornices, we'd also observe these particular features along with these cicatrizational signs. The patient can have entropion, the patient can have trichiasis if the lids are involved. So these would be the particular signs of scarring that can be present in this condition. The cornea can be involved in a lot of cases, as I've already explained the fact that the conjunctiva is in close relation to the cornea as well as in close relation to the sclera. So it can result in the infectious states of the sclera as well as the corneal involvement can occur. Cornea, as we know, it is the outermost transparent layer over the iris, and behind it, the lens is located behind the iris. So if the cornea is involved, if there is a corneal haziness phenomena or corneal opacities occur in the individual, it is going to result in the decrease in the visual acuity of the individual. So it would be included in the presenting complaints, and we can say that in this particular individual we have the pemphigoid vulgaris, and alongside we have the corneal involvement as the complication. So these patients usually suffer from superficial punctate keratitis. That is, the keratitis is the infectious state of the cornea. So the keratitis would be superficial in its nature, and it would be punctate in its nature. The ulcer formation would be rather punctate in its nature. There would be secondary microbial keratitis. It can include the superimposed bacterial infections in the individual. So these can be the situations that arise in this particular pemphigoid kind of a situation. The lid sequales would include, again, the cicatrizational signs. It can be included in the cicatrizational signs. If the lids are included, if the scarring occurs at the lids, we can have blepharitis, we can have symblepharon conditions, or we can have trichiasis, which is basically the inward direction of the eyelashes, which serve as a foreign body sensation on the conjunctiva, and further irritation of the conjunctiva and the cornea occurs due to this trichiasis condition that can arise, and obviously it can result in the entropion, that is the inward directed eyelids. So this would be the entropion, and the trichiasis would be the lid sequales or the lid complications that occur in the pemphigoid vulgaris or the ocular conditions of the mucous membrane pemphigoid. Then finally, we have the systemic features. So alongside with the ocular features, we have a lot of systemic features that we can see or that we can look for in the individual. In these patients, we'd be looking for the mucosal involvement. That is, again, very important. Specifically, what would be the regions of the mucous membrane that are involved? We'd be, first of all, examining deeply the oral cavity of the individual. The anal region and the vaginal mucosa would also be involved. They'd also suffer from the inflammatory conditions or the inflammatory outlook. There would be the redness, the swelling, and it would be exhibiting the features of irritation in all of these at all of these mucosal levels, whether it is the oral cavity, the vagina, or the anal region of the patient. The desquamative gingivitis would be another feature. So first of all, when we would start examining the patient in detail, we'd be looking for the oral features in these individuals. First of all, there should be this specific kind of an exposure and the light exposure to be beneficial enough to examine all of these features, specifically the mucosa of the individual. Then the gingiva of the individual should also be examined. Gingiva is basically the borderline between the teeth and the mucous membrane that is lying below that. So this gingival membrane should be examined in detail over here, and that would reveal the desquamative changes over here. There are these common associations with it. There are a lot of common associations that are associated with the desquamative changes of the gingivitis that are occurring over here. Then there are going to be the vesicles and the bulla that are formed on they are basically the dermal manifestations of this condition, which is the mucous membrane pemphigoid. We have a dermal condition which is the pemphigoid vulgaris or the bullous pemphigoid in the individual. Usually it is related to this kind of a dermal manifestation or this kind of a dermal inflammation that the person is already suffering from. Now, in this kind of a condition, the patient would have the vesicles. They are going to be the pus-filled vesicles on the skin that are found. It can be locally found around the eye, involving the eyelids, or it can be involving the facial structures of the individual as well, or it can be even on the extremities of the individual, involving the upper limb and the lower limb or it can be the trunk of the individual. So these can be the different sites on which we can find the bullas and the vesicles. And after these bullas and vesicles, they rupture, they're going to form these particular scarring phenomena that can also be seen, and they can also be clinically manifested over here. The trachea and esophagus is sometimes also involved along with all of these external features, relating the mucous membranes, relating the skin manifestations. Sometimes if this disease is left untreated, we can have the skin manifestations, and along with that, we can have a very complicated condition in which the trachea and the esophagus is also involved. In this kind of a condition, the patient would complain of dyspnea, that is difficulty in breathing. The patient would complain of dysphagia, that is difficulty in swallowing, that would be observed in these particular individuals, and that would be quite a chronic or quite a later, or the advancement of the disease has occurred in these individuals whenever there is involvement of the respiratory as well as this digestive tract. So that is basically indicating towards the fact that whenever we are taking the history from the patient and he's also complaining of the ocular problems, he has those skin manifestations, and alongside we have this syndromic kind of a picture in which the patient also complains of difficulty in his breathing and in his swallowing. That is basically indicating that it is a condition which has been complicated, and certainly it is the pemphigoid, or it is the ocular mucous membrane pemphigoid in the eye. Alongside, we have a bullous pemphigoid condition that has occurred in the individual. The differential diagnosis of the ocular mucous membrane pemphigoid would also include the other causes of the conjunctivitis, obviously. The other causes of the conjunctival irritation and the conjunctival inflammatory conditions or the hypersensitivity reactions that usually occur at the conjunctival level. It can be the different drugs that are being used by the patient, and that can show the hypersensitivity type 2 or type 3 reactions that would really similarize with this kind of a pemphigoid condition that occurs in the individuals. There can be these conditions of the bacterial conjunctivitis, viral conjunctivitis. As you can see, there is this inflammation that is occurring at the canthus. It's involving, as you can just observe over here, we have this a layer of basically it's kind of a mucous membrane that has been formed over the conjunctiva, and that is giving way to a kind of an irritative purposes as well. There is not a lot of discharge that is coming out of the eyes, and so we can exclude the bacterial, the viral, and the allergic conjunctivitis over here because they always contain a kind of a mucopurulent discharge that is coming out of the eyes. So we can just exclude that over here. It's just the irritative purposes that we're going to focus on. But then there are a lot of conditions, the cicatrizational conjunctivitis, a group of diseases which is known as cicatrizational conjunctivitis, which includes this pemphigoid kind of mucous membrane. Then we have Stevens-Johnson syndrome. Then we have Lyell's disease. They have a similar picture in which there is not a lot of discharge coming out of the eyes, but there are still the irritational properties of the conjunctiva that are occurring at the ocular level. So we have Stevens-Johnson syndrome that is quite similar to this kind of mucous membrane pemphigoid over here. Stevens-Johnson syndrome or a patient of Stevens-Johnson syndrome is, as we'll be studying alongside the features of Stevens-Johnson syndrome, and we'll be studying them in detail, there would be a complete picture of this individual. It's just not quite similar to this mucous membrane pemphigoid in which we have the vesicles and the bullas and the other mucous membranes of the body are also involved. It has a typical picture that is indicating that it is the SJS syndrome in this individual. It's again an emergency kind of a condition. It's not a chronic condition. The hypersensitivity to drugs can be just calculated by the history. The patient would give you a history that he's using some kind of drugs specifically that are quite notorious towards producing of the SJS syndrome. It can be the allopurinol, chloramphenicol, a lot of antibiotics. A lot of people show hypersensitivity to these kind of drugs, and they develop this kind of a syndrome, which is known as the Stevens-Johnson syndrome. The treatment of the ocular mucous membrane pemphigoid would relate to a local treatment. You just calculate in your head that we have these three major categories of treatment always whenever we have the ocular pathologies. Mainly we have a topical treatment, then we have a systemic treatment, and then we have treatment for the associated features along with that. So the topical treatment would be including the tear substitutes. We'd be giving these tear substitutes to just hamper down the irritation that is occurring at the conjunctival level. And then the antibiotics for the superimposed infections, they would be also a part of the topical treatment. And we can also induce steroids for the reduction of inflammation in these patients. Then whenever we are considering the steroids, we have the three major categories of the diseases. That is a milder form of a disease, a moderate form of a disease, and then finally we have a severe form of the disease. For the milder disorders, we have dapsone, that is almost 1 milligram per kilogram, and then we have the moderate kind of diseases in which we have the antimetabolites. Specifically, we have methotrexate at this level. And then we have the severe form of the disease in which we use the IV prednisolone, can be used in some of the conditions, and it can be we can just negate the use of this IV prednisolone, and we can just focus on the use of cyclophosphamide and the oral prednisolone rather. So this use of steroids is a usual entity whenever we are treating these patients of mucous membrane pemphigoid or the ocular mucous membrane pemphigoid in general. Then obviously we can also revert to the surgical interventions. As we already know, it's a chronic kind of a condition that is arising in the individual. So we can revert to these surgical interventions where we can treat the complications that are arising due to this condition of the mucous membrane pemphigoid. Particularly when we're talking about the ocular complications, we already talked about the corneal involvement, we talked about the scleral involvement, as well as the lids can be involved that can result in the sequelae of the lid entropion as well as the trichiasis in the individual. So all of these needs the treatment, and that is only the surgical treatment over here. So we have the punctal occlusion, that is one of the treatment that is given over here. And what punctus we're talking about? We are talking about the lacrimal duct punctum over here that is sometimes blocked due to this massive irritation that is occurring. So we have this punctal blockage that is usually at the medial canthus, and that is resulting in a lot of inflammation at the lacrimal sac, and the nasolacrimal duct is also involved over here. And so thus we perform this punctal occlusion for this individual. Then we also can perform the silicone hydrogel contact lenses whenever we are fearing that the cornea can be involved along with the conjunctiva, and still it has not completely involved the cornea, it has not caused the punctate keratitis in the individual. We can just protect the cornea by just instilling this silicone hydrogel contact lens that would basically provide as a covering layer to the cornea, as an external cover or as an external protective factor towards the cornea. So sometimes this is also done for the patients, and then we also perform, or we try to correct the trichiasis, the inward direction of the eyelashes is sometimes corrected surgically, as well as the entropion is surgically corrected. Then we have the ocular surface reconstruction that is sometimes performed, and finally we have the corneal transplantation. If the corneal ulceration has occurred, the dendritic ulcers has formed on the cornea, we perform the initial investigations that are just relating to the amount of damage that has occurred to the cornea. And if it is hindering the visual acuity of the individual, then we will perform these corneal transplantations for the individuals. Keratoprosthesis is also done in these individuals in scarring, and obviously whenever we are fearing that we have already transplanted the cornea and scarring is also involving the prosthetic features, then we perform these procedures as well. Then we can have the mucocutaneous blistering disorders. So it's basically the acute mucocutaneous blistering disorders, and that includes a list of diseases, including the Stevens-Johnson syndrome and the toxic epidermal necrosis, which is abbreviated as TEN, and it's also known as the Lyell's disease. So all of these conditions are included in the mucocutaneous blistering disorders. As the name indicates, the mucous membranes, as well as we have the dermal manifestations in these diseases, and it is blistering disorders. There are a lot of blisters that are involving the mucous membrane, as well as the dermal locations are also localized over here. Specifically, when we talk about the Stevens-Johnson syndrome, it's a blistering disorder, which is basically the type 3 hypersensitivity reaction that is taking place towards different kinds of drugs in the individual. It results in an acute emergency condition in an individual. Usually you would get these patients in the emergency departments. It is one of the rare emergencies of the dermal manifestations that you'd come across in your emergency department. So you should know how to diagnose these cases of Stevens-Johnson syndrome, and you should also have a preview towards the clinical manifestations or the clinical picture of a person who is suffering from or maybe suffering from the Stevens-Johnson syndrome. We should know how to distinguish this patient of Stevens-Johnson syndrome from the TEN, that is the toxic epidermal necrosis, as well as the pemphigoid bullous or the bullous pemphigus conditions that arises. So we'd be considering the Lyell's syndrome as well over here. And whenever we consider the Lyell syndrome, it's another condition which is basically relating to the toxic epidermal necrosis. Again, there would be the Nikolsky sign, and then there are these particular features in which the skin is also sloughing off. There is this acute emergency condition in which there are a lot of bullous pemphigoids as well as a lot of vesicles or as a lot of blisters. They arise on the skin of the individual, as well as the eyes are involved along with this SJS and the Lyell syndrome. So the etiology that we'd be considering, or we'd be dealing with the etiological factors alongside. It can be a lot of drugs that result in both of these conditions. It can be either TENS, that is the epidermal necrosis, or the SJS. A lot of patients would give you a history of the usage of the sulfonamides or anticonvulsants for the first time in their life, and they usually present as a drug hypersensitivity reaction in this particular way. Then a lot of infectious conditions, for example, Mycoplasma pneumoniae. Then we have a lot of viruses that can also result in this kind of hypersensitivity reaction. That is the herpes simplex virus, as well as adenovirus is sometimes resulting in this kind of hypersensitivity reactions. The symptoms would include the acute onset of fever and skin rash just after a short time duration after you took the first dose of sulfonamides, or after you took the first dose of any anticonvulsants that you have been put on. The patient would give you a history that he had a fever and he had this typical kind of a skin rash that he noticed. And then finally, arthralgias, that is basically indicating the pain in the joints. So the patient would also give you a history of this joint pains alongside. And then obviously the red eyes and the tiredness, the malaise, the chronic fatigue, that would be also observed alongside. Then the respiratory tract symptoms and the esophagus is also sometimes involved in this kind of hypersensitivity reaction. The patient would complain whenever there is involvement of the respiratory tract. The patient would be complaining of dyspnea, difficulty in breathing, tachypnea, that is a raise in the breathing rate. That would be obviously noticed by the patient as well if it is severe enough, and obviously on examination you can also note down this tachypnea. If you note down the respiratory rate of the individual. So these would be the typical features that we'd be looking for whenever we are considering that this patient is suffering from some sort of hypersensitivity reaction to drugs or any viral infections. The systemic signs would include the classic target skin lesions. So as the patient would give you a history of a skin rash, there would be these target lesions that you can also examine, as well the patient would be complaining of these target lesions. The hemorrhagic inflammation of the mucous membranes, it can be the mucous membranes of the eyes as well as the oral cavity, the vagina, the anal region. All of these mucous membranes can be examined, and you can notice the hemorrhagic conditions or the inflammatory hemorrhagic conditions that are arising over there. Then finally, we have the ulcerative stomatitis. This can be one of the condition, and the Nikolsky's sign. Nikolsky's sign is basically a dermal manifestation that is manifested over here. It's basically the sloughing of the skin. There would be an extreme dryness that would be observed on the skin, and then there would be this feature of the sloughing off or the wearing of the skin in the individual, which is known as Nikolsky's sign. It is part of the Stevens-Johnson syndrome, as well as it is the part of the toxic epidermal necrosis in the patients. Then moving on, we have the ocular signs of the mucocutaneous blistering diseases. We have the papillary and the mucopurulent conjunctivitis that the patient would be suffering from. We have the pseudomembranous conjunctivitis in these patients. Then we have the episcleritis. So as the conjunctiva lies in close relation with the sclera and the cornea, for the same reason, the patient can suffer from episcleritis, scleritis, as well as the patient can suffer from a lot of conditions of the cornea relating to the corneal ulcers, as well as the inflammatory punctate keratitis that can arise in the cornea. And these can obviously the ocular complications that arise alongside with the Stevens-Johnson syndrome. Obviously, if the cornea is involved, we can have the conditions of the iritis that also occurs in these patients. The ocular signs would include the conjunctival scarring and the symblepharon formation. Symblepharon is the terminology that is relating to the scarring tissue that occurs between the bulbar and the palpebral part of the conjunctiva. So there would be the scarring that occurs. There would be the scar, that tissue that develops between these two conjunctival layers, and obviously for the treatment of this kind of a complication, we have to revert to the surgical interventions in the individuals. Trichiasis and the other lid deformities are also seen in these individuals. Obviously, these can be the later complications that the patient can suffer from, as well as the patient has a dry eye, a xerotic condition that the patient is suffering from, resulting from the loss of the goblet cells. It is the result of the loss of the goblet cells that we have the dry eye syndrome. So the lacrimal gland is going to be involved, as well as the goblet cells are going to be involved over here. Then the patient can have the corneal neovascularizations and ulcerations, as well as a condition of keratitis that can involve the cornea. And due to all of these conditions, whether it is the ulceration, there can be the permanent perforations that arise at the corneal level. So as a result of all of these complications, the patient suffers from a massive decrease in the visual acuity as well. The management would obviously include the systemic management, and it would include the management of the associated features. If it's the eyes that are involved mostly, we have to just revert to the features of the eyes and how can we just justify the stoppage of the different ocular complications that are arising in the patient. The suspected diagnosis of the Stevens-Johnson syndrome or the toxic epidermal necrosis, first of all, you have to rule out the infection. For that, so you have to just perform the culture sensitivity in these individuals, and the biopsy would just finally confirm the diagnosis in these individuals. Then finally, we have the life-sustaining measures that you would perform. As I've already mentioned, it's an emergency state that has arisen. So just discontinue the offending agent. If it's a drug that we just started, we discontinue the usage of the drug. The pain and the nutrition management is again very important over here. Then finally, we perform the eye evaluation, as it is a very important structure involved in this kind of hypersensitivity reactions. So we just look at the uptake of the fluorescein stain. It basically relates to the corneal involvement. If it's a yes, we just limit to the bulbar conjunctiva. The defect is more than 1 centimeter, then we just perform the amniotic membrane transplant for the corneal involvement and for the replacement of the cornea, and the further complications would be hindered on. If there is no uptake of the fluorescein stain, we just perform the conservative management. We'd give the protective features towards the cornea and the conjunctiva. Topical antibodies and adhesions and the corneal management would be given to the patient just as a protective factor. If the defect is less than 1 centimeter, again, we just revert to the conservative management in this particular patient. If the defect is more than 1 centimeter and if it's a no, again, we just perform the conservative management. Then there is a large diameter bandage contact lens, and sometimes we also give a scleral lens for the protection of the sclera as well as the protection of the cornea in these individuals. The epithelial defects after 7 to 10 days, they are also observed in the individual. First of all, there is an initial examination and we give the conservative management or we perform the amniotic membrane transplant. And after a week or so, we perform another examination in these individuals. And furthermore, we can sometimes, if it is indicated, we perform the amniotic membrane transplant there so. Sometimes we just revert to the conservative management. It is depending upon the case of the individual. If it's just the conservative management that we can deal with, then we just revert or we just stick to the conservative management rather than a surgical intervention. The initial exam or within 4 days of the symptoms of the onset, we just add on the systemic pulse steroids and the topical steroids as a protective factor in these individuals as well. In the initial exam or within 7 days of the symptoms onset, we just revert to the conservative management. So it can be a high-ended treatment, just coupling up with the steroids, or it can just be the conservative management in the individuals. It is going to vary according to the case and according to the complications that are occurring in the individual. Sometimes we just add the topical steroids if they are indicated. The systemic treatment would include the intravenous immunoglobulins, controversial role of the systemic steroids. It would be just balancing the positives and the negatives in a particular patient. The replacement of the sloughing skin, that is the Nikolsky's sign, and the maintenance of the hydration. So these would be the typical features that we would be considering whenever we have these patients. The systemic treatment would also include the topical tears and the steroid drops, topical antibiotics, pseudomembrane peel, and the symblepharon lysis. That is the surgical treatment of the symblepharon, which has occurred as a complication over here. Then obviously the prevention of further exposure to the main agent or the major agent over here. Then we have the secondary cicatricial conjunctivitis, that is basically the injuries to the conjunctiva, the trauma, which can be due to the thermal, due to the radiational, or either it can be the chemical burns that are occurring. Then we can have the infective conjunctivitis that occurs. It can be the viral pseudomembrane conjunctivitis, which is quite notorious for the development of this kind of secondary cicatricial conjunctivitis in the individuals. We have another variant of conjunctivitis, which is basically known as the toxic kind of conjunctivitis. These toxicities occur due to the infections, as well as these occurs due to the use of certain kinds of drugs as well. It can occur due to the infectious states of molluscum contagiosum. Now what happens is basically their type of the chronic follicular conjunctivitis, it occurs due to this molluscum contagiosum, and the toxic cellular debris is discriminated in the conjunctival sac. And as it is further on discriminated into this sac, the molluscum contagiosum nodules, they arises on the conjunctiva. Another variant includes the chemical toxic conjunctivitis, and obviously it is relating to the use of different sorts of the topical antibiotics or even the steroidal agents. If they are used topically, they sometimes result in this kind of conjunctivitis. The topical preparations that are most notorious for the development of this kind of conjunctivitis are the idoxuridine, acerine, and pilocarpine, neomycin. Then we have the DFP adrenalines, and preservatives like the lens solutions can even predispose to this kind of chemical toxic conditions that are arising in the individuals. So over here in this lecture, we just summarize the different sorts of cicatricial conjunctivitis cases. Then there are a lot of hypersensitivity reactions or syndromic conditions, for example, the Steven-Johnson syndrome and the Lyell syndrome. All of these are the inflammatory hypersensitivity reactions, and one should know how to diagnose these cases. And again, one should know how to manage these emergency cases as well. So that is the end of this section. Thank you for watching sqadia.com.